I have to know what button to book. Okay. Hi, everyone. All right.
Hi.
All right. That's much better. So I figure if I click every button, that eventually will happen, but sometimes it's disastrous if I do that. So anyway, okay. All right. So what do you want to do? Want to start with the first question?
Mm,
Uh,
we would like to first introduce ourselves. And
Sure, please. I'm sorry. Yeah, I
Yeah,
had your names all there, but yeah, please introduce yourselves. Yeah.
so, yeah, today we invited you to make a video interview about lung cancer. We're doing a project in our Global Perspectives class about this topic, and we would like to invite someone who knows about this topic, about the current situation in America, how the lung cancer in America is going on, and so I think you're the best person that we could find.
That's very nice of you. Thank you.
Yeah. Thank you for receiving our invitation. We're very grateful for that.
Mm.
And yeah, we're so excited today to do this talk. And
Mhm.
please introduce yourself to our viewers.
Okay, so do you want me to introduce myself? I can do that.
Yeah.
So I'm
Yeah.
Theresa Mcloud. I'm a radiologist. I know Kulan's, Anujan's mother, Kulan, is, I got to meet her in Mongolia the first time when I visited, and we've been friends for a long time now. And she actually came and visited me in Boston and spent some time in our department. So it's been very nice. So what I do, I'm sort of a professor at Harvard Medical School, and I'm what we call a vice chair in the Department of Radiology. I'm in charge of education, and I'm a thoracic radiologist. That's all where I've done all my research and so forth has been in just thoracic radiology. So lung cancer was appropriate. I became, involved a bit in working with, lung cancer screening and so forth. So, we'll talk about that. And it's interesting to see how the approach to lung cancer has changed a lot because I'm not that young and I've been around for a long time. So I can tell you a little bit about that history and some of the advances that have been made. So I live in Boston, and Boston is not a bit further north from New York. It's right on the coast of the Atlantic Ocean. Has a lot of universities. Harvard is there, and I think you've probably heard MIT, the Massachusetts Institute of Technology, and so forth. So so it's a great place to live. A lot of young people, a lot of students, and it's great. And it's a great intellectual atmosphere as well. So, and it's a fun city to live in. So, okay, so that's enough for me. So why don't we go around and maybe you can each tell me a little bit about yourselves. So I'll answer your questions, and please just, if you want to raise your hand or whatever, if you have another question or you want to make a comment or something. Okay. All right. So your first question was, what is lung cancer? Well, it's like any other cancer, the cells of the body just grow out of control. They proliferate, they divide, they become more numerous, and they take over and destroy other areas of the body. So obviously with lung cancer, they start in the lungs, and then one of the problems is to spread. They spread first to lymph nodes. You know what lymph nodes are? I think you probably do. Yeah. Okay. Lymph nodes. And then distant metastasis, other organs of the body. And that's common with lung cancer for that to happen and to happen fairly early. And sometimes patients aren't diagnosed. They don't find out they have lung cancer till it's spread into multiple other organs. So that's lung cancer. Now, there are two histologic types, cell types. One is called small cell cancer, and the other is non-small cell cancer. The small cell cancer is the minority. It's probably less than 10% of cases. It can be treated easily in the beginning, but it always recurs. And the other is non-small cell lung cancer, which is less lethal and which can be treated more readily, and the survival is much better with the non-small cell lung cancer. And that's probably almost 90% of cases are non-small cell lung cancer. And they're treated differently. I mean, they're treated sometimes with the small cell, they don't treat usually with surgery at all. They just treat with different medications. And so they're just different types of cancer. And so they're treated differently, and the biologic behavior is different as well. Any questions on that?
Yes.
No.
Oh, no, no.
No? Yes? Yeah. Okay, what's your question? You have a question?
No.
No? No, okay, all right. I thought I saw you. Yeah, okay, let me bring that down. All right, fine. Then you asked about what are the risk factors, who is susceptible to lung cancer? Well, in the United States, the lung cancer is associated with cigarette smoking in 80 to 90%. So it's the overwhelming cause of lung cancer. And it can be cigarettes, but there's also an association with pipes and cigars, not as much. People, I don't think, smoke pipes or smoke cigars as frequently as they do, as they do the regular cigarettes. So if you get people to quit smoking, it's going to reduce the likelihood that they get cancer, but it doesn't completely eliminate it. So if smoke for 10 years and you're age 40 and you give it up, every year that you're not smoking lessens the likelihood that you're going to get lung cancer, but it never goes away completely. So the other issue, some other things, are risk factors, is what's called secondhand smoke. Say you grew up in a family and your parents both smoked, you would not be directly inhaling what is in the, in the tobacco and all the other products that are carcinogens, but you would be exposed to smoke. So there is a risk. It's not huge, but it's something to think about. And my own father smoked heavily. He gave it up, and it was really tough for him to give it up. But, I lived in that house. We didn't think anything much. And he'd sit at the table at dinner and he'd smoke and so forth. So, I was exposed. Fortunately, I've not had any problems at all, but it's something to think about. Now, there are a few other causes of lung cancer, and they're rare. One is radon. That's a gas that's kind of in the earth and the soil, but it can get into houses. And sometimes because, especially in the winter, and I know you have very cold winters, so you understand, but all the doors and the windows and everything is closed. And there's not enough air, air coming from the outside. And so it's like a gas. It forms a gas that can be trapped in home. Estimated 20,000 deaths from radon in the United States a year. I had to look that one up, but much less than lung cancer. And then there are a few other substances. One is asbestos, which is pretty much banned around the world, but it was kind of a liner. They will wrap pipes in it. It's an insulator. They put it in homes because of okay, it's been uploaded. Okay, all right. So anyway, it's now banned. So it's the people that were exposed years ago that get into the problem, and they can die from. They can get this tumor that's in the lining of the lung called mesothelioma, but actually most of them die from lung cancer because they work, especially the asbestos workers. They smoked when they worked, and they tend to get lung cancer instead. Okay. Any questions on that? No? Anything you
No.
didn't understand or anything? Okay. So, what are the ways of early detection? Well, there really at the moment is only one recommended way of detecting it early, and that involves the radiologist. Okay, so it's CT, computer tomography, low dose, thin sections, and so forth. And that's now proven to be efficacious in several studies. The first one was an American study that involved over 50,000 people, so a very valid study, and they were able to show that there was a 20% decline in the control group, not in the control group, yeah, in the group that was being monitored for, and stopped smoking and so forth. And they had, control group as well. And they showed the decrease in those in the control group that were actually being screened and those that were not in the control group and weren't being screened. So, so that was, and that's basically was over 20%. And that's what's considered, a good margin if you can decrease a disease, say whatever it might be, by 20%, then the government comes in and says that fella, we should do something about it. We should have a screening program, because if you can reduce death by 20%, that's a public health benefit. Okay, so screening came into effect. And there were certain criteria. So what did you have to be to get screened? One is you had to have 30 pack years with heavy smoking. So the pack years means the number of packs per year. So for example, if you smoke 1 pack a day for 30 years, that would be 30 pack years. If you smoked 2 packs for 30 years, that would be, that actually doubles it to 60 pack years. Okay, so it's the number as soon as you smoke 1 pack of cigarettes a day, and then if it's more, then that goes into the equation. So you have to have at least 30 pack years of smoking in order to qualify for the screening. You can be a current smoker or somebody that quit within 15 years. And why 15 years? Well, if you quit for 30 years, say you were a teenager and you were smoking heavily until age 30, and you're now age 60 and you haven't had a smoke since then 30, the risk of lung cancer goes way down. Okay, so it's probably not worth the cost and everything to screen you. Okay, so those are the. And then who should be screened? And these are all this is American government decision, okay, with the input of scientists and so forth. 55 to 80 years old, okay, so and they're thinking of reducing that to 50, okay, so, and these are the groups that are most at risk for having lung cancer, and these are they thought that would benefit for lung cancer screening. Now that sounds great, but what do you think might be a problem? Are any of you familiar with CT scans? Have you ever had one or seen somebody that had? You know what a CT scan is? It's basically, you get put in this big machine, a tube, and it takes, images, and it's in black and white, of course, but of the organs in your body. And this would be the lung, for example, and it can pick up abnormalities, very well. And we use a low dose, so the dose of radiation is pretty small. So, and the patient lies, so you don't have to do anything. They don't have to get any contrast. They just kind of lie in the gantry, and it's done in, 10 or 15 minutes. So really easy for the patient. Okay. So let me see now. So the only thing is that works, as I said, it is this lung cancer screening. And that was proven, as I said, by the trial at the NIH in the United States. And there's been a European trial that came out of the Low Countries, Belgium, and the Netherlands, and a very good study. The methodology was a little bit different, but they also prove that they could save lives, and it's at least 20% of lives by screening. So that's pretty well done. So that's about the only method that we really have, is to try to detect the lung cancer early in these people that are at risk because they're heavy smokers. And how often do we do it? It's recommended to do a CT scan once a year. Now, the problem is that there's something called a lot of false positives. I think you know what a nodule is. It's just a little round speck, that you can have in your lung. And probably I must have some. Maybe you guys have some. Not cancerous. I know this, don't look alert. But they're these benign nodules. Some of them are what we call granulomas, like certain diseases like TB or histoplasmosis can give it to you. All sorts of reasons why you can get little nodules in your lung. So we have a lot of false positives. So how do we decide what to do with that? Well, you follow people to see if these nodules grow. If they grow, they're likely to be a cancer. Okay. And then the size is very important. If we don't really need to, follow and do other studies if the nodules are less than 6 millimeters, okay, because those are so likely to be benign, and you've got to screen people every year anyway. So that's basically it. But that's a problem, and we're trying to do everything we can to decrease these false positives, because it means a lot of testing and expensive and so forth. But you is very good at picking up cancers. It's very, very sensitive at picking up cancers and early cancers. So, so that's basically, so the screening, as I said, is done yearly. If there's, say, a large nodule, there are a whole criteria for what you do when you find something, a suspicious cancer. And I don't want to spend a lot of time, but you do a diagnostic study to try to stage the cancer to see if it's spread any place outside the lung. And if it hasn't spread, they usually do surgery. And they may wait to see if a nodule is more like a centimeter before they'll start to do intervention. It depends. It depends on how fast it's growing. It depends on if you find something, you can watch it for a while. If it starts to grow, then that's a bad sign that it might be cancer and you work on treating it. Do you understand that? Is that okay? Yeah, okay. So then you asked me at what age do patients get sick? Now, lung cancer is usually a disease of older people. The largest number probably over the age of 70. But as I said with the screening, it seems reasonable to start at age 50, and particularly for the heavy smokers, because there are younger people, when they get cancer of any time, the cancer is usually very aggressive. It's a bad cancer. It tends to spread more quickly than it does in an older person. So this is the reason for screening them. But it's usually older people. Now, what happens, where is the cancer? So the cancer can be in really two areas. One is that you have, your windpipe or your trachea, okay, that goes down into your lungs and it carries air into your lung. So a lot of cancers originate in those tubes, they're called the bronchi, but others will originate in the actual tissue of the lung and the substance of the lung. So, and patients can have different symptoms. If it's in the airways, that first group, they often have a cough, they can cough up blood, they can lose weight. There are all these symptoms, the problem is once they become symptomatic, usually the disease is already spread. That's why screening is important, to pick up the disease early. Okay. All right, let's see. I talked about the airways, coughing up blood. Weight loss is another symptom. And sometimes people present in the cancer is already spread, and often it spreads to the brain, which is interesting. So they might come in with a seizure and you do an MR scan of the brain and there are a couple of lesions there, and then you look at the chest x-ray, or it doesn't have the feature of a neurologic tumor, so you look at the chest x-ray and there's a lung cancer there. So some of these are very aggressive and the patient doesn't have symptoms until they spread elsewhere in the body. So that's again why screening is so important. If you wait till the patient gets symptomatic, it may be too late. So that's the issue. So they often don't develop symptoms early, and that's why screening helps. I think you asked about let me see, I have the answers here without questions. It was number 5. Let me just okay. What is the survival rate of people with lung cancer, and which factors it depends on? Well, it depends on the stage. Okay, we determine the stage. Is it just limited to the lung? Has it spread to the lymph nodes? Has it spread elsewhere in the body? Okay. And there are 4 stages for classification. So one is localized, which is just in the lung, and regionals at nearby sites like the lymph nodes that drain the lung. Then distant is distant spread to other organs in the body, such as the bone, the brains, the liver. Now, the statistics before treatment, if you don't do any treatment, is if it's localized only in the lung, the survival is only 27%. So it can be a very lethal tumor. If it's regional with the lymph nodes involved, 16%. And if it's spread to other organs in the body, it's only 3%. Now, treatment is always changing. Treatment is getting more aggressive. So those numbers have improved. More people are surviving even with later stage cancer. But, at the beginning, just looking at the time the patient's diagnosed, looking all the data over the past 5 years, you say these is the likelihood of mortality. Any questions on that?
No, not really.
All right. Let's see. All right. Now, how many people have it in the U.S.? The numbers are high. I can give you the death numbers. It's estimated for 2021 that there will be 1,031 deaths, 1,031,000 deaths for 2021. And the number of cases, that doesn't include the people who are still alive, for the past year was 235,000. So still a lot of people that have lung cancer.
100?
No, 235,000. Okay. So that's the number of new cases, and the number of deaths was 131,000. And part of that is because, as I say, it doesn't get detected unless people are screened. It doesn't get detected until later because the symptoms occur later. Okay. Sometimes with other cancers, like a cancer of the stomach, for example, and so forth, people get the symptoms much earlier and often before it spreads. So that's part of the problem. Okay. So the next question is, why is mortality higher than other cancers? So I think I've already mentioned that. Late diagnosis, they don't, has already spread. The tumors are aggressive, both the small cell and some varieties of the non-small cell. They're tumors that replicate quickly and spread quickly. Okay, they're aggressive tumors. So that's the other problem. And the only definitive treatment, by that I mean a person absolutely cured, okay, is from surgery where you actually remove the tumor. And people have surgery and then die later, and that's because the cancer is still present somewhere else, but we just couldn't detect it, so that's the problem. But if it's early and you remove it, and surgery's changed a lot. In the early days, if you had lung cancer, they took out your whole lung, okay? And then it was just a lobe in the lung, and there are 3 lobes on the right side and 2 lobes on the left side. Now they do these much smaller resections if it's an early cancer. So it's just a small tissue, a bit of tissue around the cancer and the cancer itself. So that, it means much less morbidity for the patient. The patients don't suffer so much from the surgery. And if it's early, that can be a cure, We follow up all patients. Say you had a cure. Okay, you're 2 years out, you had the surgery, they got rid of the small cancer. And we follow those every year because the likelihood of you getting another lung cancer is higher than the general population, probably because you're a smoker or whatever. So we do a CT scan every year on all those people who've been cured with surgery, okay? So surgery is the only cure, and it's in the early stage lung cancer where it can be done. Okay. Now, you asked about the methods of government. Our government gives directives. It doesn't usually have an awful lot of rules, as you probably, if you follow American politics, you can see that. But back in 1964, which must sound like eons ago for you, but anyway, there was a report from the Surgeon General, who's a representative of the American government, about the link between smoking and lung cancer. And it was definitive. So it changed the whole attitude about lung cancer. And a lot of the pressure was, public health messages and pressure on businesses and so forth. And then there were laws as well. So they start off with don't advertising. We watch our television shows all the time. There are always cigarette ads. Okay, that stopped. Then there were smoking bans. Can you smoke in a restaurant in a laboratory? No. Okay.
No.
No, so no smoking in public places, and most businesses won't allow people to smoke. Okay, so most large gatherings, at sports events, you can't smoke. You can leave and there'll be a smoking area you can go to, but you can't smoke around other people. And then our government system for healthcare, for older healthcare patients, they pay for the screening. So patients can come and be screened every year, and their Medicare pay for it. And because the government was involved, it created all these rules about screening and how we had to keep records and so forth. So the government has really helped. So we can track this, and again, we'll have many more patients, and we can test again and see how valuable the screening has been. Okay, so they've been very helpful with that. You can't buy cigarettes in the United States if you're under the age of 18. That's against the law. And, they keep an eye on that. And if there are, what often happens is that the teenagers get what we call false identification. They'll get somebody else's identification that's older, and then try to get the cigarettes, but they have to check on it. And if there's a store that's selling cigarettes to younger people, sometimes they close them for a month or something like that. So, they're pretty careful about that. And then, as I said, the government requirements for the CT screening. The sad thing about screening is that the numbers are low. They're probably still less than 20% of people who are eligible to be screened that are getting screened. Now, what's the reason for that? Well, they have to go to a center that's set up to do screening. There's a lot of information we have to collect. We have to be responsible for reminding patients to come back for their annual screen, calling them if they need another study, all that. So you had some investment, and the government doesn't pay for that, actually. So small practices and small hospitals don't want to take on that burden, so it's the big hospitals. And if you live in a rural, a farm area or something, the US is a huge country and you don't have a hospital that close, it's large enough to do it, you don't get screened, that's the problem, or you have to travel a long way to get screened. So there are attempts to try to make this all better, and the numbers are going up. But, this is the only way you can really reduce the those terrible numbers of deaths, is by doing the screening, and people aren't utilizing it as much as they should, so we do everything to make it as easy as possible and keep people come into our hospital. So that's good. And we have a wonderful one person dedicated, that's to your staff, secretarial person. She follows everybody. She lets the referring doctor know what the results are and so forth. So, but you have to have the infrastructure and the resources to do that. Okay. Now, the other thing that was produced in the US is like a standard way to report what we see when we screen. And it's, it has to do with the size of the lesion and so forth. And then there are directives of when you follow the patient up. If you find one of these nodules, if it's less than 6 millimeters, you probably don't have to do a follow-up. You just have the patient come back in a year for their regular screen. So, and then when does it get suspicious for cancer, and what should you do, and so forth. So these are all agreed upon standards that everybody who does lung cancer screening has to follow and have available in their reports when they report it to the referring clinician. So that's been very good. And that's the American College of Radiology really developed those standards, but it was with the support of the government. So, okay. The other thing, not run by the government, but it's kind of more public health sources and so forth and contribution. But there are what are called smoking cessation centers, where if you want to stop smoking and you find it very hard, you can go to somewhere and get some counseling, and people will help you and give you advice on how to stop smoking. So those are available, at least around most cities. And the hospitals always have that information that can give people. And now we're kind of requiring that every physician always ask a patient, have you ever smoked? So when they come in just because they have, a swollen toe, they get asked whether they smoke cigarettes and for how long. So you can get them into a screening program. So that's all happening. Now, the next was lung cancer. So any questions on that? I'm sorry, I'm just talking away here. No?
Oh, it's okay.
Okay, all right. Well, lung cancer in women, and absolutely it's increasing in women. And why? Lung cancer deaths in men is decreasing, and in women it's increasing. Now, one may be that women started smoking later. Men were smoking. If you look at any films of World War II and the Korean War, the Vietnam War, and everything, the U.S. Army gave out tons of cigarettes to soldiers and so forth. But it was considered, inappropriate for women to smoke. This was just not a thing they should do. You see it in the movies, but you wouldn't see it but that all stopped and women started smoking. And it may be, since you don't see the cancers until maybe 30 or 40 years after the person starts smoking, then maybe that's the reason that we're seeing, these increase in the numbers of women because they started smoking years later than men did. But and there's some indication that maybe women find it harder to stop, and there are a lot of young girls like yourselves, okay, in school that have social pressures, to have a smoke, that's that sort of thing. So, but the interesting thing now that's going on with all the research in lung cancer is finding that the biology of cancer, lung cancer, and its relationship to smoking seems to be different in women. And there's all this genetics that's done. There are genetic mutations and so forth again. There are drugs that have been developed to deal with that. There's something called EGFR, which is a mutation that some women have. It responds well to therapy if their cancer has that mutation. So this is all, I think, encouraging. And often the women get what's called an adenocarcinoma. It's usually in the periphery of the lung, not in the center of the lung, so it can be caught early. So again, it's important to get women screening every year because you can pick it up when, can be usually managed by surgery. And if not, it can be managed by some of these drugs that are related to the gene therapy. So new treatment. Surgery, as I said, is much more limited than these. They do smaller areas of surgery. They always, the tumor spreads to the little lymph nodes, and there you have lymph nodes all in your body, and there are a lot in the mediastinum next to the lung. So they always sample the lymph nodes to make sure there's no tumor there. But they can, the surgery is getting better and better. Radiation therapy. Now, the thing is that a lot of these therapies are used together. Patients might get drugs, chemotherapy, but they could get radiation. And there's something called SBRT, which very localized heavy dose radiation just to the tumor itself that seems to be very effective. So these are often patients that don't have surgery. Now, why wouldn't they have surgery? Because their tumor is too advanced, or there's a risk of having surgery. They're older patients, they have other problems, and putting them, having surgery would be a danger for them. So for medical reasons, they can't have surgery. So you use these alternatives. And then there's chemotherapy, these drugs against work on various types of cancer. And then have you heard about immunotherapy? It's the latest thing that is very, very exciting. I mean, it basically, they're what we call these checkpoint inhibitors that your body could, because it creates an immune response in your lung. It can be too much, or they can't turn it off. So what they do is these drugs can turn off some of the immune response, and they call these checkpoint inhibitors. And then it means that the response of the drugs that are being given is actually greater on these tumors. So this immunotherapy is being used, chemotherapy, sometimes they use a combination of all these. And what does that mean? Well, it often means that the survival of patients is longer. And I think we may, as these drugs keep getting more and more improved, that lung cancer, and I'm talking about the type that is advanced and, is not going to respond just to surgery, but those sorts of lung cancer can become like a chronic disease. It can be managed for a long period of time, just like diabetes, for example. And we're seeing more and more of that, these patients that come back and then problems. I mean, they're somewhat immunosuppressed, so they can get infections and all. But, most of these patients with a stage 3 or 4 cancer were dead within a year. And now you see them come back 10 years later and they're on all these drugs, but they're still living. So there's a lot of research going on. And I think it's kind of very exciting that there are these advanced and combination ways and that people can live a lot longer as a result. And so that's the encouraging thing. And you said, what's my advice to you young ladies? Don't smoke. Okay. All right. That's the important thing. That's the best thing you can do for yourself is don't smoke. Okay. I know it's tempting sometimes, but that's the best thing that you can do. Okay. All right. Any questions now? I've given you a lot of information. Anything I didn't cover or that you want to know about? Don't be shy. No? Yeah.
Can I ask a question?
Sure, of course.
I just like I want to know about like how many of the people like diagnosed with lung cancer like had an initial information knowledge about this, and you told that like clinical centers, medical centers give people provide people with sufficient information, but maybe people in rural areas don't get the sufficient information. They don't know about lung cancer. They don't know that smoking could like result in something very bad.
Hmm.
What do you think?
Yeah.
How many people in the have this knowledge, and could the knowledge like about its harm help in its prevention?
Yeah. A very good question. Yeah. I think people know that lung cancer is very bad. And, we talked about what the government was doing to inform people. I remember this was years ago when, the people were there was sort of a ban or there are all these indications that people were in strong. And they had a couple of these television stars, they were, what American cowboys are, anyway, but they had been heavy smokers and they came forth to indicate that were dying of lung cancer. And you remember them from the movies, and they were these, very masculine, cowboy, muscular guy. And they looked like, they were about to die. I mean, and I think some of these statements from these people saying don't smoke was just compelling. It gets to the average person when you look at the media and television and social networks and so forth. There's a lot of public health information. Everyone really tries to get out the word about screening. And I think physicians too. I mean, as I said, people do see, most people have what we call a primary care doctor, or in England, they call it a general practitioner. And so, but they usually check on them. Are you smoking and so forth? They come once a year and they give them information. So it's hard trying to get all the information out there. People are at all curious. And I think everybody knows that smoking is bad and they know the link to lung cancer. I think that's kind of usually understood. And a lot of it is a question of just encouraging people to come see their physician and try to get a screen. But I think it's improving. We're getting more people. I mean, there are a lot of effort. There are a lot of what we call not-for-profit organizations. There are groups that anti-cancer and so forth, the American Cancer Society, and they take all sorts of efforts to get information out there to people and, write articles and so. And I think social media is helping too,
Yes.
and that's a great way to disseminate information. So So people do, I think most people, they have the health insurance to be able to be screened and so forth. But it's a lot of it's motivation. Some people are deniers too, and it's so forth. But I think the important thing, if they go to their doctor for anything, the doctor now has to ask, do you smoke? And how much do you smoke? And maybe you should be screened and so forth. So it's a battle, you know. How about, well, let me ask you, I mean, uh, do you have any screening programs available? I know they do in Europe, and I'm sure there are other countries that have their own screening programs, or is that not in operation, or is it too much of a burden for the health system to initiate screening? No? Did you understand? Do you have a screening programs for cancer, or you
We
know?
don't know about that.
Okay, all right,
We're not
fine.
sure.
But do you see any, you know, advertisements or any messages in the media or social media or Facebook or anything that give you information about stopping smoking? And
Yeah,
yeah, there's some of that. Okay, all right. So
but
that's,
not
it's
that
a big
much.
effort. Yeah, but not much. Yeah. Okay, I understand. Yeah.
Mhm.
Okay. What's the percentage of people who smoke, adults who smoke in Mongolia? Do you have any idea?
No.
No. Okay.
How many people smoke in Mongolia in adults?
Mm-hmm.
Mainly men.
Yeah, okay.
Yeah, mainly middle-aged men smoke, and nowadays a lot of you know, kids, children of our generation, teenagers start to smoke.
Teenagers, yeah.
Yeah, and
Not like cigarette, but vape or like
Mhm.
that things. Mm,
Okay, yeah.
and
Yeah, well, before the Surgeon General's report in the 1960s, 45% of the US was smoking, and it's now down to about, last I heard was 18%, and that's at least a year or two old. So there's been, yeah, a huge difference. Yeah. And I mean, it's inconvenient to smoke because you can't smoke anyway. You can't go into an office, you can't do anything and smoke, you know. So it takes a real effort to smoke. And I think, you know, people are trying to, you can smoke marijuana, it's legal in the state in which I live. I can't smoke cigarettes. Okay. All right. That's good. Yeah, that's the important thing. Yeah. Okay. Any other question?
what would you advise to Mongolia? Just like Mongolia is a developing country.
I know. Yeah.
I
I
think
know.
we lack of screening tests. Not everyone can afford this, so we think the government should do more about this, as lung cancer is the third most common cancer in Mongolia, and I think future predictions tell us that it will increase, the number of lung cancer will increase as it develops through the like, you know, like from an early age. If you have started smoking and if you've been smoking for your life, then there's no risk of you're getting lung cancer. So
Yeah, I fully realize that setting up a screening system is not practical, but I think it's public health information. There should be education in the schools, you know,
yeah,
and about the effects. And, you know, if you ever wanted something like in your own school, I can send you slides and all that sort of. So education, I think, is the important thing. And then in the health system, at least when you go to see a doctor. Now, do most people have a specific doctor they go to, or do they just go to the emergency department of the hospital when they're sick? Or do you think people regularly see a doctor?
no.
No, yeah, but whenever they do, that the doctors are instructed to ask them if they smoke, to tell them the dangers of all that. So, but I think, and then there has to be, you know, public health on maybe on your social media, on television to get the word out and they advertise it out and say, you know, don't smoke, you know, it can be public health messages that come out through the media. And I think that's probably the best way to do it is education and spreading the word and making, because it's probably impractical to have a screening program, at least at this time. So, so anyway, the government could do that. And I don't think it's a huge investment, and it might get partners that would help, you know, you know, I don't know, people that sell healthcare equipment and so forth, you know, that they might contribute to setting up these, you know, these public health announcements by whatever media is available, whether it be social media and it's Facebook, or whether it be on your television or on your radio and so forth, and just get that message out, you know. And sometimes it helps if somebody on TV can interview somebody who's got lung cancer, you know, that's so important, you know, when you actually see somebody that, you know, and maybe somebody who's not that old and has, you know, advanced cancer, and say, don't smoke, you know, that has an impact. So I think public health messaging is probably the best way to go for now. Does that sound reasonable to you? Yeah. Okay. All right. Well, I hope this is helpful. I hope they